Welcome to the PT on Ice Daily Show. My name is Dr. Jeff Musgrave, Doctor of Physical Therapy, proudly serving the older adult division for the Institute of Clinical Excellence, which is bringing you this podcast. So I am super pumped to discuss this new study that I just came across. So what we have is a study titled Impact of Mobility Limitations on Geriatric Rehabilitation Outcomes, Positive Effects of a Resistance Training Resort. This was just published in September, on September 5th. It's an interesting article that looks at inpatient patients, and it's actually a twofold article here. Their first aim, wow, some balloons, that's nice. The first part of this article was observational in nature, to figure out what happens to patients that are unable to walk when they go into the acute setting. So they were looking at outcome measures to see what their length of stay was, what their change in mobility status, their nutrition, their cognition looked like, if they were unable to walk or if they were able to walk. Then the second part, there was actually a study within a study, kind of like one of those nesting dolls, you know? So the second part was called the Lift Up study, and it was a feasibility study that they pulled from the same group of inpatients, of the 710 geriatric patients. And what they were doing with the Lift Up study was to see if resistance training was feasible in the acute setting. Now, some of you in the acute setting that are already doing resistance training probably find that laughable because you know you can do resistance training in the acute setting. But they were looking at doing 2 15-minute sessions twice a day for 5 days a week for these clients in the Lift Up study. And the Lift Up study only included those who were not able to ambulate. So the first part was pre-admission, who can walk, who can't, and then just seeing what happens to them. And then the subset of the study was identifying those who could not walk, which was 50% of the 710 at admission could not walk, and then seeing what their outcomes looked like. So really interesting to see these two things put together. So the inclusion criteria here, any older adult who was able to sign the consent and was not on palliative care was given the option to enroll in this study. And then so they ended up with 710 subjects, and their average age, we ended up, just want to make sure I don't misquote this, almost 78.8 years old, so almost 79 years old. So these are older adults, well into later phase of life. So what they did is outcome measures here. They were looking at length of stay in the hospital, their frailty score, looking at that reserve or lack of reserve to see where they are on the spectrum from robust to frail. The short physical performance battery, if you're not familiar with that, it's got static balance, it's got a 5-time chair rise, and a gait speed component to it. And then they use the FAC. So that is a functional ambulation classification, and it's a quick 5-point scale. So if you're not familiar with that, you're just assessing the way someone walks on this 5-point scale, and then they track that as an outcome as well. They also track cognition, but I couldn't find in the study what they used for that. There was a geriatric screen that they used to try to figure out their baseline level of function. I believe the cognitive piece was included in there. So the observational part, we'll get to the results there, but the study within the study, the Lift Up, of those who could not ambulate, they did progressive resistance training. It was 2 15-minute sessions a day. From the feasibility standpoint, they used the tried and true TheraBand. These are people who can't walk. They're probably primarily in a seated or supine position, but they made it very simple, very run-of-the-mill, but they were just very consistent. So they only had 3 resistance options. They had the yellow, they had the red, and they had the green, baby. They had 3 types of resistance options, and then the movements that they did, they had an upper body split and a lower body split. So their movements were a chair raise, so coming up to stand. They had a hip thrust, glute abduction, lateral pull down, chest fly, shoulder abduction, and prone hold. So those were their movements. They did an upper body split and a lower body split on those movements each day for 5 days a week, 2 15-minute sessions, upper, lower body. And in addition to that, they got usual care. So if someone was going to be working on ADLs, if they were going to be doing some gait training, well, they were non-ambulatory, but transfer training, standing training, like normal care, and then they had this additional 2 15-minute sessions a day. So on our first observational study, piece 1, what they found is patients that were not able to walk pre-admission had worse cognition, they had a higher frailty score, and their malnutrition risk was higher. They had lower improvement in their independence in their acute care stay, pre-admission and post-admission. So they spent more time in the hospital, they were sicker, nutrition was poorer. So just at baseline, if your patient can't walk and we're not able to change that, there's a good chance their outcome's going to be poor. And I know that sounds obvious, like an obvious assumption that most of us would make, but we have it here in the literature. We can see it. And then of the people that were included in the Lift Up trial, so we had 710, half of those couldn't walk. Of those half, they only had 15 participants, so a small number in comparison to the entire cohort. But of those that did the progressive resistance training, the Lift Up program, they found that they were able to change their walking ability as well as their independence and ADLs. So they were able to make some change in gait speed, and they were able to improve their independence with progressive resistance training. So these are kind of assumptions. These are biases. This is kind of a bias confirming study from the perspective of most of us that are on ICE faculty. But the reality is, it's feasible and safe to do resistance training within the constructs of acute settings. And we know that based on this, it looks like there's going to be a positive association for those doing strength training in the acute care setting to improve their independence and to improve their independence with gait. And just to back up, when we look at the body of literature for geriatrics, we know that gait speed and independence with gait is like the sixth vital sign. We know people that walk slower are likely to have poorer health outcomes, whether we're talking about rehospitalization, quality of life, independence with ADL, safety in the community, falls risk. All of that is related to gait speed, and most specifically 1 meter per second. So I think when we're thinking about this, preserving that ability to walk is really important. I know that our patients come to us with different goals. Prevention, if you are someone in a subacute setting or in an outpatient setting, building strength and building resiliency and the ability to walk could help have a protective nature. There's a strong correlation between the ability to walk and having positive health outcomes in the context of acute settings, but also long term. So this really just adds to the body of literature that promotes strength training even within the acute phases of rehab for geriatric clients. They need resistance training. They need strength training. It will improve not only their independence, but their gait speed. So if we find someone who is not able to walk, strength training is going to be helpful. Not just our transfer training, not just our isometrics, not just those, what we would call probably pretty underdosed exercise. And I would say within the context of these studies, of this study, those movements are not greatly functional in nature. The chair rise, absolutely. But some of this is just low-hanging fruit, very simple exercises to execute, but that also should give us a lot of hope. If we can make these exercises more functional in nature and use functional positions and use more resistance, then we can be really hopeful that we're going to have a positive outcome in the acute setting to help our patients get out of the hospital sooner with more independence. And then on the other side is just bolstering the reserve, strength, and their ability to do gait training or ability to walk, hopefully before they end up in the hospital. And heck, as much as possible, prevent these hospitalizations, because we know strength training is protective in nature when we look at the body of literature for older adults. So if you're interested in taking a deep dive into the study, I'll have the DOI linked in the show notes. As well, if you're not familiar with the FAC, the Functional Ambulation Scale, and you're interested in using that, I'll have a link to the Shirley Ryan Ability Lab if you want to check that out. If you are interested in hopping in to learn more from the older adult division, we've got our level 1 course starting on the 6th of January. Make sure to hop into that if you want a fresh start and deep dive into all things geriatrics. Level 2 starts on, if you've already had level 1, level 2 starts on the 7th. Last course of the year is December 8th in Loveland, Ohio. We've got tons of course offerings for 2026. If you didn't see, we've got that special offer where you can lock in the 2024 rate on pricing, because prices are going to go up, and then you can choose later which course fits your schedule, fits your geography, fits your interest, whether it's an older adult or it's one of our other great course offerings. So that's what I've got for you. I hope you have a wonderful Wednesday. I hope that we reinvigorated your interest in resistance training across settings, but not to count out our acute care clinicians who are working hard, grinding to take care of these really sick patients, but also to give you some hope that resistance training may be a huge key based on the recent literature. Team, have a great day. We will catch you next time.